Hello and welcome to the latest seminar from the Glasgow Centre for Population Health, supporting new approaches to improve health and tackle inequality. In this videocast, Professor Sir Michael Marmot from University College London delivers this keynote presentation on social justice and health equity. In his talk, he provides timely and important insights and learning from his vast experience and career, and offers his thoughts on emerging from the COVID-19 pandemic and building back fairer. It was recorded via Zoom on the 25th of May 2021.
Okay, so hello, good afternoon and welcome to the third seminar of the 17th Glasgow Centre for Population Health seminar series. And as I remember being at the first one, which is presumably 17 years ago, that makes me feel really quite old. My name is David Walsh and I work at GCPH and have the pleasure of chairing today's event. Today's speaker is obviously Professor Michael Marmot, and I will introduce him properly just in a wee second. Before I do that, I have a number of what used to be called in pre-pandemic days when we were all in the same room, housekeeping issues, as lots of us are still in our own houses. That makes no sense whatsoever. So I instead have a number of things to tell you about the running of the seminar. So we're on till 3:30 and we will end promptly at 3:30. That's part of my role as chair to make sure this is all kept to time, and I'll do that. Professor Marmot will speak for roughly 45 minutes. Now, in a normal webinar, you would have the option of submitting questions via the question and answer function, which I, in my role as chair, would then put to Professor Marmot. Just because of the sheer numbers today, we had 1,000 people almost registered for this. It's just not feasible or practical to do that. So the Q&A function has been disabled. The chat function has also been disabled, so you just need to sit nicely and listen and not chat among yourselves. And instead, after Professor Marmot has spoken, we are going to have an expert panel, each of whom will respond briefly to what they've heard in the main presentation, and then ask questions of Professor Marmot. And that way we'll keep the discussion going with him. The panel comprises Dr. Gwanetta Curry from the University of Edinburgh, Marianne Scobie from the Glasgow Disability Alliance, and Professor Morag Traynor from Heriot-Watt University. I've also got a few questions that have been submitted in advance from audience members, so if there's time, I will get to them and put them to Professor Marmot as well. Before anyone asks, and then somebody else asks, and then somebody else asks, yes, the event is being recorded and it will be available for you to see in a short while. We'll let you know when that's there. And the slides are also available to download. If you are of a tweeting disposition, then the hashtag is GCPHSEM17, so GCPHSEM17. And I've promised to say nothing negative about Twitter, so I would encourage you all to tweet away. Okay, so to our speaker, well, actually, if there's ever a case of a man who needs no introduction, especially if you work in public health or related areas, it's Professor Michael Marmot. In the unlikely event that someone is here who doesn't know who he is, maybe you've joined the wrong seminar by mistake, I shall now introduce him. Having said that, if I were to read out his full biography, which was provided to us, not only would there be no time for questions at the end, there'd be no time for a seminar because it's incredibly long, and that reflects obviously a very important and distinguished career. So I've just plucked a few headlines from it. He is Professor of Epidemiology at University College London, has been since 1985, and has over 50 years of leading health inequalities research. In that time, he has authored various books and countless research journal articles. He is an advisor to the World Health Organization on the social determinants of health. His awards amassed over his career include 19 honorary doctorates. Surely there's a university out there that could round it up to a nicer 20 figure. A knighthood and the WHO Global Hero Award. And of special relevance to today, he led the 2010 and 2020 Marmot Reviews, the clues in the title, on health inequalities in England. And although their focus was England, the evidence amassed in them and the recommendations included in them are clearly highly relevant to ourselves in Scotland and indeed elsewhere. And his focus today is again on inequalities, but it's about inequalities as we seek to emerge from the current crisis. So in the words of his latest report, how we build back fairer. So in that sense, this event couldn't be any more timely, and we are enormously grateful for his time. So I will now stop wittering away and instead hand over to Professor Marmot. Thank you very much.
David, thank you. It's a great pleasure to be here, and Glasgow could always make it 20, but reasonable suggestion. you can see my screen?
Yeah, we can see your, yeah, that's perfect. Thank you.
Good. I published 2 reports recently with the same title, Build Back Fairer. And the underlying principle of both of them relates to the first line of my book, The Health Gap, which was why treat people and send them back to the conditions that made them sick. Particularly during a pandemic, the health care system looms large. But I'm dealing with the social determinants of health, the conditions that make people sick. So the second of the reports with the title Build Back Fairer was a commission that I chaired on social determinants of health in the Eastern Mediterranean region of WHO. And when they heard that that was the title of my English review, Build Back Fairer, the COVID-19 Marmot review, they said, we want to be with that title. We want to build back fairer in the Eastern Mediterranean region. So, and the title, Achieving Health Equity in the Eastern Mediterranean region. Our commissioners, I chaired it. Most of the commissioners, of course, were from the region, a couple from the United States, Srinath Reddy from India, but across that region of the world. And our conceptual framework built on the conceptual framework that we had for the WHO Global Commission on Social Determinants of Health. Then we adapted that for our European review and our review in the Americas. So we have structural drivers, and we had chapters and recommendations corresponding to each of these items. So conflict and consequences, economic and commercial determinants of health, culture and society, the natural environment, and those influence the conditions of daily life, maternal and child health, early years, education, employment and quality of work, healthy aging, built environment, and health systems. And as I'll show you in a moment, our general theme was do something, do more, do better. And taking action requires good governance and political cultures, policies and research and monitoring. And the outcome is health equity and dignified lives. In addition to socioeconomic difference, we were particularly concerned with the position of migrants, of refugees, and gender. The so-called Eastern Mediterranean region is remarkably varied. It stretches from Morocco in the very west of the Mediterranean, west of Portugal, not Algeria for some reason, through North Africa, Djibouti, Somalia, the occupied Palestinian territory, Israel, for political reasons, is in Europe, and then the Gulf states, Iraq, Iran, Afghanistan, Pakistan, so-called Eastern Mediterranean. I guess, again, for political reasons, Pakistan and India are in different regions. And the do something, do more, do better is because it's a remarkably varied region. Qatar, the gross national income per person is greater than $90,000, adjusting for purchasing power. United Arab Emirates, $70,000. Kuwait, $60,000. The US is $60,000. So we've got countries in the region that have the highest national income in the world. And then we've got some of the poorest countries, Afghanistan, Djibouti. So the do something, do more, do better. If the national income, and the life expectancy is on the y-axis here, if the national income per person of Afghanistan got up to the level of Egypt, it's likely that life expectancy would improve, perhaps up to the level of Egypt. do something. If Egypt went up to Lebanon or Iran, do more, life expectancy would get better. Now look at this, Iran, Lebanon, go all the way out to Qatar. And despite immense differences in national income, there's no difference in life expectancy. Tunisia, Jordan. In other words, getting rich for a country is not necessarily the way to get healthier once you get up to a certain threshold of around $15,000 per person, adjusting for purchasing power. So for poor countries, do something, do more, but for these countries up here, do it better. And then, of course, there are big inequalities within countries. If we look at under 5 mortality by wealth quintile, Pakistan, there's always talk about maybe we should focus on the poorest of the poor. And indeed, the poorest wealth quintile in Pakistan has an under 5 mortality of 100 per 1,000 live births. But focusing on the poorest of the poor misses out on the fact that there's a social gradient. The higher the wealth, the lower the under 5 mortality. It's not enough to focus on the poorest of the poor. You've got to focus on the whole social gradient. And indeed, the wealthiest 20% have higher under 5 mortality than the poorest 20% in Egypt. And in Egypt, they can't rest on their laurels. Again, there's a very clear social gradient. And the wealthiest 20%, with an under 5 mortality of around 19, ought to aim to have it like Iceland at maybe 2 per 1,000 live births. So dealing with the social gradient. And there's great need for evidence on inequities in health and social determinants. I've showed you under 5 mortality. We don't have data for most of these countries. In fact, I don't think for any of them, on inequalities in adult mortality. So examples of do something, do more, do better. Do something. This is the proportion of the population with access to at least basic sanitation. Sudan, Afghanistan, Yemen, do something. Get people clean water and sanitation. That's the world average. Bring them up at least to the world average. Kuwait, UAR, are up near 100%. So do something. Do more. This is the percent of women who agree that a husband is justified in hitting his wife. In Afghanistan, more than 60% of women agree with that proposition. A husband is justified in hitting his wife. And look at the rates in these countries. But particularly in these other countries, there's such a clear social gradient by level of education. So it's not enough to provide clean water and sanitation. Women have to have the right, satisfied, to lead a life of dignity, which means not being beaten by your intimate partner. Do better. This is tax loss to corporate tax abuse annually. In Egypt, $2.1 billion annually lost to corporate tax abuse. Pakistan, $2.5 billion. Saudi Arabia, $2.25 billion. UAR, $1 billion. Think what that tax revenue that's lost because of corporate tax abuse could be used for to improve, to do better, to improve conditions within the country. Do something. Primary school completion rate by wealth quintile. In the occupied Palestinian territory, it's 100% by wealth quintile, nearly. But Tunisia, Iraq, Pakistan, Yemen, they're very clear social gradients. Do something. All children should be completing primary school. That should be the very least that happens. Do more. Lower secondary school completion rates. Again, in the occupied Palestinian territory and in Jordan, it's relatively high, but a social gradient. All children should be given the conditions that enable them to complete lower secondary school. But it's much lower in Iraq, Afghanistan, Sudan, with very clear social gradients. Do something, do more. Do better. In some countries in the region, women participate in tertiary education to a greater degree than do men. Girls more than boys. But look what happens when they leave education. This is wage equality for similar work, the female to male ratio. So if women earned the same as men in doing similar work, the ratio would be 1. And between 2014 and 2018, in Egypt, the ratio went down from just under 0.8 to just under 0.7. And the ratio is unacceptably low in each of these countries. Do better. I said we had structural drivers related to recommendations related to each of these structural drivers. This region of the world has more deaths due to violent conflict than any other region. The majority of deaths in the world due to violent conflict occur in this region. And one of the consequences are refugees. Jordan houses nearly 3 million refugees, occupied Palestinian territory, 2.25 million. Lebanon, 1.5 million. Now think firstly of the conditions in which those refugees are living that damages their health and damages health equity. And then think of the burden on the host country. Countries with small populations like Jordan and Lebanon and the occupied Palestinian territory have these vast numbers of refugees that they have to cope with. Pakistan, much bigger population, of course, but not a rich country. Economic and commercial determinants of health. We had a lot to say about that, not just corporate tax abuse. But look at income inequality. The percent of pre-tax national income among the richest 10%, the middle 40%, and the poorest 50%. So Middle East and North Africa, which is the Eastern Mediterranean region, wow, the top 10% have a higher proportion of pre-tax national income in this region than in any other region. Latin America likes to declare itself the most unequal region in the world. If anything, Middle East and North Africa, the Eastern Mediterranean region, has even bigger income inequalities. And the UN recommends that all developed countries should allocate 0.7% of gross national income into official development assistance. We did do that in the UK. Shamefully, we've cut it drastically. I say shamefully, it is shameful that we've done that. We recommended that the rich countries of the Eastern Mediterranean region should give 0.7% of their gross national income in official development assistance to the poorer countries within that region. So in the UAR, their ratio was higher than 0.7%, but it's gone down, as it has in Saudi Arabia. So these rich countries are nowhere near making that 0.7%. culture and society. There's a lot, of course, of religious friction in this region between different religious groups. That's potentially a negative impact. But religious practice is associated with good health, and faith-based organizations in the region provide essential services and funding to low-income and excluded communities. And part of culture and practice is what I showed you before, not agreeing with the proposition that it's acceptable for a husband to beat his wife. The natural environment, it was rather challenging and confronting in a region much of whose wealth relates to production of fossil fuels to say you should be moving towards net zero greenhouse gas emissions. But we said it. And look at this, share of benefits from electricity subsidies by income quintile, poorest, richest. Electricity subsidies are greater the richer you are. So these countries are subsidizing rich people to overconsume electricity. And then conditions of daily life. I won't go through examples of all of these, but we did have examples of all. Maternal and child health, early years and education, employment and quality work. As just one indicator, informal employment as a percent of total employment in Sudan. More than 85% of workers are in the informal sector. And all of these countries have high proportions in the informal sector. And that matters because no job security, conditions at work are not regulated, there's no occupational health standards. It matters enormously. Healthy aging. This is the proportion of population above the pension age who receive a pension. And I show this because there's a feeling that in poor countries, well, maybe you can't organize a pension. That's for rich countries. Well, it's not true. In Iraq, more than 50% of the population above the statutory pension age do receive a pension. It's not up to the world average, but it's getting there. Whereas in Pakistan, it's tiny. And we think high priority should be to make pensions available for people of pension age. Built environment, there are, of course, large numbers of slums, informal settlements throughout the region that have to be dealt with. Health systems, one example, the percent of people spending more than 10% of household consumption or income on out-of-pocket health expenses. So in Egypt, more than a quarter of the population are spending more than 10% of their household consumption or income on out-of-pocket health expenses. And 4% are spending more than 25% of their income in out-of-pocket health expenses. And similar high levels in each of these countries as shown. And then, of course, COVID-19. This was the projection of the number of people in extreme poverty, less than $1.90 a day, before the pandemic. And this is the projection of what's going to happen because of the pandemic. A dramatic increase in absolute poverty, $1.90 a day. Percent of workers who stop working as a result of COVID-19 by wealth quintile. It looks like the figures in Britain. The poorer you were, the more likely you were to have stopped work. A quick run through. We had, as I said, recommendations for each of those domains in the Eastern Mediterranean report. Let me come back to my English report, Build Back Fairer, the COVID-19 Marmot Review. And I've got to take us back a bit. In 2008, we published the report of the commission that I had chaired, the Global WHO Commission on Social Determinants of Health. It was a global commission. The Prime Minister of the United Kingdom, somebody whose name you'll know, one Gordon Brown, asked me, how could we apply the conclusions and recommendations of your global commission to one country, England? And so in 2010, I published the Marmot Review, Fair Society, Healthy Lives. In February 2020, before the pandemic happened, we published Health Equity in England, the Marmot Review 10 years on, to look back what had happened since my original review. And the simple summary is, we've lost a decade and it shows. What do I mean? It was an English report, as David Walsh said at the beginning, but similar findings are likely to apply in Scotland. So life expectancy had been going very nicely, thank you, improving at the rate of about 1 year every 4 years for women and for men. This goes back to 1980. I could take it back to 1890, and life expectancy had been increasing about 1 year every 4 years. And then in 2010-11, that century-long trend changed dramatically, and the improvement just about ground to a halt. That's what I mean when I say we've lost a decade, and it shows. The government of the day that was elected in 2010, the Conservative-led coalition government, they said, surely you're not suggesting it's anything we did that could have led to this slowdown. Well, we need to look at it. After all, you had as a principle austerity. Maybe that could have led to this slowdown. One question we had to deal with was, well, maybe we've just reached peak life expectancy. It's got to stop improving sometime. So we looked at other countries. This is annual life expectancy improvement in weeks, 2011 to 2017. Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, Czech, there's the UK. We had the slowest improvement in life expectancy of any rich country except Iceland and the United States. So no, we had not reached peak life expectancy. This slowdown was more marked in the UK than in any other country except Iceland and the United States. And the social gradient we see very clearly. Classify people by where they live and classify where they live by level of deprivation. The worst off 10%, of course, have shorter life expectancy than everybody else, but it's a gradient. The less the deprivation, the longer the life expectancy. The gap between the least deprived 10% and the most deprived 10% was 9.5 years for men, 7.7 years for women, and it got steeper over the decade. The inequalities got bigger. The gap between the best off and the worst off got larger. Inequalities increased. This is England, but it may have relevance to Scotland. If we look, this is women, but it's quite similar for men. For women in the least deprived decile, the least deprived 10%, if you're rich, it doesn't much matter where you live. There's relatively small regional differences, and life expectancy improved a bit for all regions. But if you're in the bottom, the most deprived 10%, it matters enormously where you live. The regional differences are much bigger, and life expectancy for the poorest 10% went up in London, but went down pretty well everywhere else outside London. So that's where we were pre-pandemic. Health had stopped improving, inequalities were increasing, and life expectancy for the poorest women and men outside London was getting worse. Now, I work on the assumption that the health of a population tells us something rather important about how well the society is meeting the population's needs. If health had stopped improving, it means society had stopped improving. If health inequalities were getting bigger, it means inequalities in society were getting bigger. If life expectancy was going down for the poorest people, it means conditions of life were getting worse for them. Wow, what is that about? Well, in my 2010 review, I had 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, fair employment and good work for all, having at least the minimum income necessary for a healthy life, healthy and sustainable places and communities in which to live and work, and taking a social determinants approach to prevention. And I'll touch on what happened to those. So the first thing was, as I said a few minutes ago, the government that was elected in 2009-10 had as their explicit policy austerity, rolling back of the state. And they did it. In 2009-10, public expenditure was 42% of gross domestic product, and that went down year by year. By 2018-19, it was 35%. 42 became 35%. And that reduction was done in a most regressive way. Here's the spending by local government per person, the grey bars, total local authority spending per person. For the least deprived 20% of areas, spending went down by 16%. And then the greater the deprivation, the greater the reduction in spending. In my 2010 report, I coined the phrase proportionate universalism. We want universalist policies with effort proportionate to need. What we've got here is an example of effort inversely proportionate to need. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Could that have led to a slowdown in improvement in health and increased inequalities? Yeah, I think it could. If you assume that the money local authorities spend does some good, if you have that kind of regressing cut in spending, then it's likely to have an adverse impact, and that's what we saw. So the first was give every child the best start in life. Children living in poverty, where poverty is defined as less than 60% median income. 2011, before housing costs, 18% of children were in poverty. After housing costs, that went up to 27%. And over the decade, the 27% went up to become 30%. Child poverty went up. And one of the ways that worked was what the Chancellor did to the tax and benefit system. So this is the long-run impact of planned tax and benefit reforms by income decile and household type, introduced May 2015. So let's look at working age families with children. if you were in the bottom 10% of household income, as a result of changes the Chancellor made to tax and benefits, your income would go down by 15%. If you were in the second bottom decile, your income would go down by 12%. And then the richer you were, the less the reduction in income. I sat with a former government minister in the coalition government, and I showed him an earlier version of this slide and said, your government's policy was to make poor people poorer. He looked uncomfortable and said, well, perhaps it was not our explicit policy. Well, they're very clever people in Her Majesty's Treasury. They must have told the Chancellor that this was the effect of the policy. Most of the 6 domains that I referred to got worse in the decade up to 2020. And then came the pandemic. And when it crashed upon us, many of us said that the pandemic would expose the underlying inequalities in society and amplify them. And so it proved. Here's the social gradient in all-cause mortality. Before I showed you life expectancy, this is just turning it on its head. So the social gradient in all-cause mortality by level of deprivation. And here, the pale green, is the social gradient in COVID-19. Almost exactly parallel to the all-cause mortality. It means that the causes of inequalities in COVID-19 overlap considerably with the causes of inequalities in health more generally. Both in England and in Scotland, there's some relative excess in the most deprived 2 or 3 deciles, which we think relates to employment in frontline occupations, living in overcrowded, possibly multi-generational households. But in general, it's a social gradient. And then when we look at ethnic differences, Black African, astonishingly high mortality from COVID-19, Bangladeshi, Black Caribbean, Pakistani, and to a lesser extent, Indian. And some large measure of that excess is related to geography, population density, deprivation, other socioeconomic characteristics. And in the case of Black African and Black Caribbean, prior health conditions do not make a difference. But for Bangladeshi and Pakistani, prevalent ill health does increase the excess. When these data were first published, and a minister in the government was on the radio, and he said he was terribly concerned about this, and people should wash their hands and practice social distancing. And I was asked, what did I think? And I said, good advice, and we should deal with structural racism. Yeah, but what should we do tomorrow? Tomorrow we should start dealing with structural racism. And when we look at excess mortality, that looks at the deaths that would have been predicted based on the previous 5 years, and then how many did occur, and that's the excess, and look at the cumulative age standardized all-cause mortality rates. During the first wave, the excess mortality in England was higher than in Scotland. Scotland was higher than in Wales, which was higher than in Northern Ireland. And the UK together had the highest excess mortality of any country, any rich country. The US handled the pandemic appallingly. The excess mortality in the UK was higher than in the United States. And I wondered, what's going on here? I've speculated that health is a measure of societal success. Pre-pandemic, life expectancy was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. And as I've shown you, that slowdown in life expectancy was nearly the slowest of any rich country, except Iceland and the US. And then in the pandemic, we had the highest excess mortality. What's the link between these two? I think poor governance and political culture, increasing social and economic inequalities, reduction in spending on public services, we were ill prepared, and we were unhealthy coming into the pandemic. Over the New Year period, the historian Lord Peter Hennessy contacted me and he said, I think your Build Back Fairer is a Beveridge report for our times. If you remember, William Beveridge produced his famous report in 1942 when World War II was still raging, and he talked about 5 giants on the road of reconstruction and said want is only one of the 5 giants, in some ways the easiest to attack. The others are disease, ignorance, squalor, and idleness. In my way of looking at things, the giant of disease is the outcome of the other 4. We could say that want is relative inequality. Being a child growing up in a household at less than 60% median income, relative inequality. Squalor, homelessness, poor housing conditions, absolute inequality. Ignorance, education, and idleness, unemployment, and I would generalize that and say poor working conditions. So in my Build Back Fair report, taking health as a measure of success, I had a series of specific recommendations related to those that I had in 2010. Give every child the best start in life, education and lifelong learning, fair employment and good work for all, having enough money to lead a healthy life, healthy and sustainable places and communities, and taking a social determinants approach to prevention. But we also have to deal with these issues: poor governance and political culture, the increasing social and economic inequalities, the prior reduction in spending on public services, and the fact that England was unhealthy coming into the pandemic. And my overall recommendation is put a fair distribution of health and well-being at the heart of all government policy. We said on the cover of the Global Commission report, social injustice is killing people on a grand scale. To build back fairer, we need to put equity of health and well-being at the heart of all government policy. Thank you.
Okay, thank you very much. A fantastic presentation with lots and lots of things to process there. So we're very grateful to you. To help us process all the messages in that presentation, we have a panel now. So if I can invite the panelists to come back in, and by come back in, I mean turn on your camera and your microphone, please. Fantastic. So I'll just introduce the panelists to everyone before we get into the discussion. So in alphabetical order, we have Dr. Gwynetta Curry, who is a lecturer of race, ethnicity and health at the Usher Institute in the University of Edinburgh. We have Marianne Scobie, who is Deputy CEO at the Glasgow Disability Alliance and strategic lead for their programme supporting young disabled people. And last but not least, Professor Morag Traynor, who is Professor of Child and Family Inequalities and the Deputy Director of the Institute of Social Policy, Housing, Equalities Research at Heriot-Watt University. Morag, you win the prize for the longest title there. So what I'm going to do is ask all 3 of the panellists, just one by one, to briefly respond to what they've heard in Professor Marmot's presentation, and then kick off the discussion by asking a question. So I'll turn to Gwynetta first, if I can.
Okay. Thank you, David. Great presentation, Professor Marmot. I will say I am from the US and I've been in the UK about 2 years, and I've been following your work for a number of years, all the way back from grad school. in today's presentation, you went through 2 reports on health inequality globally as well as in the UK. And I think these are very strong messages that you're sending in terms of the health gradient and the impact of structural inequalities. The structural inequalities that we constantly see and have seen in the UK, as someone who focused on race and ethnicity, it's very clear that race and ethnicity overlaps with these issues of socioeconomic status and health. What question I want to pose to you is that if we know that structural racism has had a direct impact on the vulnerability of ethnic minorities, particularly Black people in the UK, moving forward, how do we address these inequalities? We have the CRED report that just recently came out and rejected the idea that structural racism existed. But the data is very clear that where you live and where you stay and where you work has had a direct impact on your vulnerability to COVID-19. And what the data shows is that Black people are dying at a higher rate as what you presented. And when I think about the health of a country, a lot of times I turn to maternal health data. And with Black women in particular in the UK, while maternal health has improved, Black women's maternal mortality rates have continued to be significantly higher than their white counterparts. So I would just wanted to pose a question to you, moving forward, how do we address these structural inequalities when we have the resistance on the other side saying that they do not exist?
Do you want me to respond in turn, or do you want to take all 3 comments?
I think if you respond one by one, it's probably easier
Sure.
in terms of processing what's been asked.
Well, thank you for that. And I've been struggling with the answer to that question. As I said to you before we started the webinar, I've challenged by looking at the data. And I've had to deal lately in different contexts with people who just know the truth about everything, and anybody who disagrees with them is wrong. The challenge is not to reconcile conflicting ideas. The challenge is to convince the other guy that he's wrong and you're right. Well, I'm not in that camp. I'm troubled by the data. So when the Sewell report came out, the CRED report, I published an opinion piece and I said that structural racism, I quoted from my own report, I quoted from the report we did in the Americas, the PAHO Commission that I chaired. Throughout the Americas, people of African descent have higher mortality than people not of African descent. And indeed, indigenous peoples have higher mortality and worse health than non-indigenous peoples. And I was utterly convinced by the evidence and the arguments from our commissioners for the importance of structural racism. So armed with that approach, I then come back to looking at the British data. And when we saw the COVID-19, I said, well, that's what's going on. That's what's going on. When the CRED report said, no, there's no racism in Britain. We're lovely. We've shown the way. It's all lovely. And all these people are going off half-cocked. And it's only socioeconomic. Well, hang on a minute. If it's socioeconomic, how come there's socioeconomic disadvantage that apply to ethnic groups differentially? So one pathway by which people's ethnic position and by which structural racism can work is through social and economic disadvantage. And so in those data I showed you on COVID-19 mortality, the government data, about half, maybe a bit more than half, can be linked to socioeconomic disadvantage, geography, exposure, and the like. But there's a good deal more that can't be explained by that. Now, I don't think of racism as just a residual category. That's something I apply to what I can't explain by other things. We've got to look for the evidence. While I'm struggling with this, as I mentioned to you earlier, a colleague from Cambridge contacted me and he said, You've said explicitly that you look at things through a health lens, and that if there's health disadvantage, that's evidence of social disadvantage, which, as I've just been laying out, can be, at least in part, attributable to racism, structural racism. And he said, if I show you that there's health advantage, does that mean that there's no structural racism? So he then showed me that life expectancy overall was better for most ethnic groups in Britain than for whites. And he said, does that contradict your argument about structural racism? And I said, go away. I don't want to talk to you. Stop being a nuisance. You're troubling me. You're upsetting me. Well, I had to think about it. Then my comeback was, what about the Hispanic paradox? In the United States, Hispanics have longer life expectancy than non-Hispanic whites. And you would never for a moment argue, if you've tuned into American politics for the last 4 years, that there's deep and abiding racism against people from Latin America, Hispanic, starting with the president. I was going to say on down, actually, from the president on up. He was about the lowest of the low. So there's deep and abiding anti-Hispanic prejudice, but they have longer life expectancy. So I'm contradicting myself. The fact that there was better health is not an argument against the existence of racism. It just means we've got to think about this a great deal more. And for COVID-19, for, as you said, maternal mortality, for mental illness, there's clear disadvantage, which is in part socioeconomic, but I think of, just as I think of socioeconomic disadvantage as the causes of the causes, I think of racism as the causes of the causes of the causes. Why are people in these disadvantaged conditions? And I was speaking at the Race and Health Observatory earlier in the day, and I looked at the CRED report. I've been interested in crime. The police have been after me. Don't misunderstand. But I've spoken at a couple of police conferences this year, and I'm interested in the overlap because most young people who get locked up have a mental illness, and they're overwhelmingly disadvantaged and disproportionately from ethnic minorities. And there's clear structural racism in the police and the criminal justice system. So what did the CRED report? It referred to data on homicide, and it says it's largely due to deprivation, the difference between blacks and whites. So I went back to the Home Office, the data that they cited, and I got out the report that they cited. And I looked at the data. I even made a slide of it. If I trusted myself, I'd show it to you, but I'm not sure I trust my ability to manipulate the system. But the disadvantage, the black excess, is bigger in the more deprived areas than it is in the less deprived areas. Now, in relative terms, the excess is smaller, but the absolute excess is bigger. You look at those data, a simple fellow like me, and you'd say, hang on, that's not all due to deprivation, because the gap in the homicide rate between the excess in black compared with white is bigger in the more deprived areas. So the Sewell report clearly decided the conclusion that they wanted to draw. And then they cited the data as if it supported the conclusion. Well, okay, I'm prejudiced too. I think there's structural racism. And I look at those data and they support the conclusion of structural racism. Look at what's going on in the schools. Exclusion from school. Deprivation is clearly related to exclusion from school. but for black kids, they're more likely to be excluded than white kids within an area. It's hard to think about that in terms other than structural racism. So, although most of the reports that I've done until the PAHO report focused on socioeconomic inequalities, the PAHO report sensitized me very strongly to the issue of racial ethnic differences and the importance of structural racism.
Gwyneth, do you want to come back to any of that?
Yeah, well, I'll just say thank you for your response. And yes, and so I have noticed the transition of, you talking more about structural racism in your work. And I did read your response to the CRED report, because I also wrote a response because I felt they misrepresented the data that was out there. But yeah, so thank you for your response.
Okay, great. I'm going to move on now to Marianne. Marianne, if you'd like to respond to what you've heard today and then ask Professor Marmot a question.
Thank you so much. If this had been a face-to-face live event as such, I would have been sitting in the front row clapping and cheering at some of the phrases that you were using and some of the analysis that you had. And I do particularly like the sort of the do something, do more, do better phrase, because we do feel really powerless when the world around us is just really overwhelming and full of such inequality. So it's sometimes a bit heartening to just have something that you can think, well, actually, where can we just do something? Because sometimes things are so overwhelming that we just feel that we can't do anything. And people get very disheartened and very sort of disempowered and feel that there's nothing that we can do is ever going to make any of this any better. So sometimes just having some way to just identify where can we all do something, where can we all do more, and where can we do better as individuals and as groups, as peer groups, as society as a whole, and obviously as governments. So I particularly liked, the way that you framed all of those things. I think it's just easy for people to understand, and just to, sometimes governments need to actually have things made easy for them to understand, because as you've just pointed out, they often don't understand or agree with the hard data that you present to them. And the other thing was just in terms of structural inequality, which we've obviously, you just talked on in particular around people from Black, Asian, and minority ethnic communities. We did some research ourselves over the pandemic with about 6,000 disabled people. And what we saw in that research was that, as we expected, disabled people fared terribly during the pandemic. Disabled people of colour, faced, just absolutely, tremendous discrimination, tremendously bad outcomes. Disabled people with learning difficulties and disabled people generally. And so there's obviously something going on in terms of structural inequality in relation to disabled people. And our own research found that about 60% of disabled people face digital exclusion at a time when the whole world just said, okay, let's just do everything digitally. That's how we'll get through this pandemic. And what we found as a result of that was that 80% of disabled people that we spoke to were unable or unaware of community support. So there were disabled people living in communities that had all these sort of pop-up supports there, and they just couldn't access them. So people were going hungry, people had no one, people had social care removed, so they literally were in bed, unable to get any support to wash, dress, eat, go to the loo, and so on. Over 40% of disabled people weren't able to access the information that they needed in a format that they required it. So it stands to reason that they're going to fare worse than people who can just access information in the way that most people access it. And do not resuscitate orders, notes being put on people's notes without their consent, without their knowledge of even them or their families, regardless of their ability to comprehend that information, and regardless of what their outcome would have been in normal circumstances. So there's definitely lots of structural inequalities that we need to face, that we need to challenge. But I suppose one of the things that, as I said, starting off where we talk about do something, do more, do better, we're a community development organisation. So we believe that the people who experience inequalities should be involved in developing, designing, delivering and evaluating measures to address such inequality. And yet that's something that we don't see across the world. We don't see it in this country. So how do we actually increase the status of action research that's been developed and delivered by people who face inequality? How do we increase the status of community development, where we actually empower communities to take control of the barriers that they face, to actually challenge the government and decision makers and work together? How do we do that? So if you would have any thoughts on how that could be achieved, or any sort of indication across your vast research as to where you've seen that working, how can we address that in that way by actually involving the people who experience those inequalities? Just a wee question there for you.
Well, terrific. On the do something, do more, do better, I learned a lesson from an unexpected place. When we published the WHO Commission, way back in 2008, and the following year I was invited to ECOSOC, the UN Economic and Social Council. They had a high-level segment in Geneva, and I was invited to address the high-level segment, and the Secretary General of the United Nations quoted from our report, from the WHO Commission report. Inequities in power, money and resources, he said. I thought, wow, I got really excited. And I came home and I was sitting around the family table, and I said I was so excited that the Secretary General of the United Nations was quoting from our report. And then I said to my family, I wonder if there's one person in the world who'll have their health improved by the Secretary General's statement. And my then teenage daughter said, Daddy, even a baby step is a step. So do something, do more, do better. Baby steps make a difference. Even a baby step is a step. And when people say to me, oh, we need a revolution, I think, I don't want to live through a revolution, chaos. Let's take some baby steps. That'll do. I'd like to take some bigger steps too. But that's why the do something, do more, do better, I think is important. And I'll come back to your middle point. Let me skip to the end point, and then I'll come back to your middle about your survey with disabled people, because it relates to the do something, do more, do better. In the decade from 2010, when, as I've shown you, central government in Westminster was really not interested in what I'd recommended, but the city of Coventry declared itself a Marmot city. And I made several visits. They took my 6 domains of recommendations and said, we're going to use this as the basis of planning in Coventry. They even, when Coventry got declared the European City of Culture, they said, it's because we're a Marmot city. I said, oh, go on. You say that to all the boys. And no, because we've got all the groups in the city working together. Local community groups, the police, the fire services, local government, social care, public health, the healthcare system. We all work together. So I went to Greater Manchester and said to Andy Burnham, Coventry's doing it, which is great. It'd be really great if Greater Manchester did it. He said, fine, we'll become a Marmot City region. We've got 10 cities in Greater Manchester. So we started work with GM in 2019. Then the pandemic came, and so our work got changed. But next month, we will produce a report of our work with Greater Manchester, and we'll see if they do it. But we would like them to have a Build Back Fairer charter. And community groups have been an important part of that story. It's city government, it's local government, it's the voluntary and community service. Community groups are important in that. And we've got good evidence that they're making a difference. Gateshead's done something similar. And we've been talking to the North of Tyne Combined Authority. We're getting closer to Scotland. You know, we're getting up the Coventry, GM, North of Tyne, not far to go, getting closer to Scotland. The South London approached me last week. Would we advise them? So there's local areas all around the country that want to take this on one way or another, which is really encouraging. To come back to your main concern, firstly, I would love to see a report of the work you've done with the disabled. Please send me your report. I'd love to see it. Because really, for the first time with the PAHO Commission report, we highlighted the issue of disability. And we said that all of the social determinants of health, exactly as you've just described, apply even more so to people with disability. And you've described that during COVID, but even more so. And again, with the PAHO Commission report, for the first time, we talked about intersectionality, which again, you've referred to, that women of colour who are disabled have several disadvantages. So it's even more important. And I'd very much like to see your report. And thank you for highlighting it.
Marianne, do you want to come back on any of that?
Just very briefly, thank you. And of course, we can send the report to you, and we'd be delighted to. And I think that the one caution I would say in relation to what you've said is that it's really important to remember communities of identity exist, not just communities of geography. Because quite often, if you're excluded from your geographical community, you may come together in other ways as a community of identity or interest. But so disabled people may be more likely to come to be a community of identity than a community of geography. So it's just to put that out there as well. Thanks.
Great, thanks very much, Marianne. So I'll pass now to Morag.
Thanks very much. And Sir Michael, I'm really glad you started with the WHO Eastern Mediterranean report and brought it down to the report for England, because that's given me some food for thought about how we action this, or what we do as regards implementation in Scotland. So at the start of the presentation, when you were referring to the Eastern Mediterranean region, you talked about 3 things that need to be in place. The first of these was governance and political culture. The second of these was policies, and the third of these was research and monitoring. And these 3 things need to be in place in order to reduce the inequities or by socioeconomic gradients, or indeed by ethnic or disability or other equality group gradients. So if we look at Scotland now, thinking about those 3 criteria, and we think about Scotland, we have a government who has very much shown, a devolved government, that's very much shown commitment. The governance and political culture and will is there. So there is a stated commitment to improve people's lives. We have, after the Child Poverty Act of 2010 was abolished by the UK government, we have the Child Poverty Act of 2017 for Scotland that has not only adopted but extended the targets of the original act. More recently this year, in fact, we have what will become full incorporation of the United Nations Charter for the Rights of the Child into Scots law. So I'd like to think about this through a framework of children's rights. We also have such other things as a social renewal advisory group that the Scottish Government set up, whose report, If Not Now, When, talks about building back fairer or building back better. And we have the independent care review that resulted in the promise to the children of Scotland. So we have, if you like, we have the governance, the political culture, the commitment, we have the policies, we have research and monitoring, although I'm sure Gwyneth and I have discussed this before, we have a lack of data in key areas, so we cannot monitor things effectively. So in spite of these things, the only thing I would say is perhaps within policies and legislation is we have a tension between what happens at the devolved nation of Scotland and of course at the UK level where many powers are reserved. But despite having those three things in place, I would argue there can still be an implementation gap, or implementation not happening as quickly as effectively to make those changes to enable us to build back better. So I suppose my question to you is, in spite of arguably having those three things in a good condition, we still don't have that action on the ground that's making the radical difference. As you noticed in your slides between Scotland and England, Scotland did better than England, but not much better compared to other countries. So our implementation is somewhat lacking in spite of having those three core things. So how would you suggest that Scotland could build back better? How does Scotland affect the implementation that the political will appears to be there to effect?
Well, thank you. And thank you for the challenges. I should say that, let me preface this by saying the last thing I want to do is to get involved in Scottish politics. So so I need to be a bit careful as to who I'm telling you who's spoken to me and who I haven't spoken, because I really don't want to get involved in Scottish politics. But I was approached by one or two senior people in Scotland saying, would you do a review for Scotland like the one you did for England? And my answer is, if I get invited to, I'd be delighted. I mean, there are a lot of good people in Scotland. You don't need me to do a review. But if I were invited to do a review in Scotland like the one I did in England, I'd be delighted to, because I'd like to answer your question. And it goes back a while. When Harry Burns, your neighbour, was Chief Medical Officer for Scotland, he and I were very close. We were sort of soulmates. And he used to say, I think Scotland's more like a Nordic country. And I said, Harry, you're deluding yourself. You'd like it to be like that, but it isn't. You've got deep-seated deprivation, huge inequalities, deindustrialization. There aren't, Sweden, Norway don't have the deserted dockyards of Glasgow, of the Clyde. They're wealthy countries and they don't have the deep-seated, long-standing inequalities that Scotland have. So you're British, so we would have these arguments. And I say, I really don't want to get involved in the politics of Scotland, but it relates to your question of, well, and I remember having that feeling. I went to a meeting, can I confess where it was? At Murrayfield. I thought, Murrayfield, wow, I didn't know it was a real place. But it was at the Scottish government. I held a meeting at Murrayfield. It was very exciting to be there. Not that I'm a great rugby fan, but, I've always, Murrayfield, it's like Twickenham going to. I did go to the one in Dublin once as well. I went to a meeting. Anyway, I went to a meeting in Murrayfield, and there was one Scottish minister after another. They were really talking a good talk. And I said, this is terrific. And somebody whispered to me, he said, yeah, they talk a good talk. Wait till they get a devolved budget. Then the good talk won't be quite as good because they won't have the money to do what they want to do. So part of the implementation gap may well relate to resources, just how much money there is around. I mean, I remember when David Cameron was Prime Minister, and he would, every time he was asked about the NHS, he would talk about whales. And I thought, why is he talking about large marine animals when he's asked about what they... No, he kept saying Wales. And so I went to Wales, and I said, what's all this about? They said, yeah, he can talk about the fact that we haven't funded the NHS, but we get the money from Westminster. And they haven't given us the money to fund the NHS. So it's all very well for him to claim that we're not doing it. And the First Minister of Wales, who I met, Mark Drakeford, when he was Minister of Health, and again when he's First Minister, by my lights, he knows everything I know and a good deal more. He's terrific. Nothing I can tell him that he doesn't know. And so the question of and Wales tends to be less healthy than England. So the question of the implementation gap is probably partly, at least in part, related to resources and the deep-seated challenges that deindustrialization and long-standing poverty has left. And I skipped over, I said very briefly when I showed the social gradient in mortality and COVID-19 mortality, I said it's similar for Scotland, exactly the same. The same social gradient, slightly for all causes and slightly steeper for COVID-19. Yeah, it almost overlaps with the English, but at a slightly higher level. So I'd love to do it, to do the study in Scotland and figure out what it's about and to be able to advise you because you've raised some very important issues.
We have a large audience today, and I remember from looking at the list that there's quite a large number from the Scottish Government. So there's an open invitation to you all. So we'll look forward to hearing back from you. Morag, do you want to come back on any of that?
Yes, just a thought I was having while you were speaking, and that is completely, understand where you're coming from about where implementation gaps can emerge. But then there sometimes, and I'm not just talking about the Scottish Government, I'm talking about the UK government too, and there are probably other governments that do the same, that when they bring out a new policy or a new piece of legislation with targets, that at the time you think to yourself, that won't be possible without such radical, revolutionary action and change. Is it even right or ethical to have targets that seem unattainable or likely to be unattainable without radical change? Or is that already disheartening from the outset? Or is it necessary to set the standard high and then have an implementation gap? So that, I suppose that's a bit of a personal thing, is what do you think would be the right approach for governments to take when there's always necessarily almost an implementation gap when they set ambitions so stratospherically high?
Well, I'm smiling. David Satcher, a former Surgeon General in the United States, was a commissioner on the WHO Commission on Social Determinants of Health, and then again on the PAHO Commission that I chaired. And when he was Surgeon General, I think they were planning, I'll embarrass you, Gwinnetta, it was probably Healthy People 2000 or 2010, I think, maybe Healthy People 2010. And they had as a target, abolish racial and health disparities. They talk about disparities, racial ethnic disparities. The US was very slow to acknowledge that they had socioeconomic inequalities. They do, huge ones, but they're very slow to acknowledge it. But abolish racial ethnic disparities, as they call it. And I'd been on a committee when Labour was in government in the UK, and we said reduce the inequality gap by 10%. And I said, David, you wanted to abolish them, and we were thinking we were really ambitious to reduce them by 10%. And we missed our target. We didn't make it. And when you said abolish them, who held the can? Who was responsible? Who got hauled before Congress when you didn't meet it? So what was the point of having that big target and, to use your language, more or less building in an implementation gap? And he was totally unapologetic. He was very clear-eyed about what he'd done. He didn't think they would abolish it. He didn't think the steps would be taken that would abolish it. But what he was saying was, we could if we wanted to. We don't think this is necessary to have these racial, ethnic disparities, as they called them. We could if we wanted to. And that's why we gave our WHO Commission report the title, Closing the Gap in a Generation. And I used to say, when I talked about it, it was not a prediction. I didn't think we would close the gap in a generation, but it was a statement that we had the knowledge to close the gap in a generation. We had the means to close the gap in a generation. They were just maldistributed, those means. Did we have the will to close the gap in a generation? So to come back to your question about Scotland, I think we should ask, do we have the knowledge? Do we have the means? And do we have the will? Maybe it's a way to think about it. And I've already referred to potential lack of resources. What does that mean? Let me just come back to, do we have the means? I'm already out of date in what I'm about to tell you, because there was updated last week, I think. But early this year, there was a report, I think in January or February, that there were 651 billionaires in the United States. And I say I'm out of date because the report last week said there's something like another 110 since the pandemic began. 651 billionaires in the United States. And from March to December last year, their wealth, their combined wealth, increased by $1 trillion. 1,000 billion dollars. It's hard to keep track of the zeros. Which means, there was a lot of debate in the US about these $1,400 checks as part of the COVID recovery bill and so on. It means that these billionaires could write checks for $3,000 for every single one of the 330 million Americans and have the same wealth that they had before the pandemic started. Is there resource around? Yeah, there's a lot of resource. It's just maldistributed. Now, in the UK, the Financial Times, the FT had a report on this last week, and the increase in the number of billionaires was not as great in the UK. They didn't do as well as they did in the US. But there's a lot of money around. And how it's distributed is really very important. And indeed, one of the messages from the pandemic, and I'm going to make David's task of stopping this in 4 minutes easier because I'll stop in 1 minute. But one of the lessons from the pandemic, remember at the beginning when the Chancellor said, whatever it takes, we can spend money when interest rates are low, 0 or negative, when the Bank of England can print money, whatever it takes. And that's why I called my report, Build Back Fairer. Let's close that implementation gap.
Indeed, and that's a fine point to more or less finish on. You've also mentioned big questions there about what power Scotland has to narrow inequalities. So I look forward to those recommendations in the Marmot review for Scotland, then, that you've now promised at least twice to do. So that's great news. We're at the end, I'm afraid, and that's a real shame because there was lots of other things that I wanted to bring up, including from other audience members, but we've just run out of time, so I'll just have to stop. We've had a vast amount of really important evidence and a vast amount of really helpful discussion. We've noted the promise of doing work for Scotland. I also noticed your plea for an honorary doctorate from Glasgow University. So there's lots of people from Glasgow here as well. So all these things have been recorded and they're all there for them all.
Well, you suggested, not me.
I was only joking, but you seem serious. No, only joking. So I just wanted to close by just saying a few thanks. So first of all, to Michael himself. If anybody's ever done a 45-minute presentation followed by a panel discussion, you'll know it's quite mentally tiring. Michael has just come from a previous 2-hour seminar and is now going to another one after this. So you have my utmost admiration for doing that and all our gratitude for doing it. Thanks also to the panelists for your helpful questions, responses, and general discussion. Thanks to the organisers. I don't mean me, I mean Carol Frame and Jenny Coyle at GCPH, who put all the work into these things. And fourth and finally, to the audience for being part of this. We hope you enjoyed it. If you did, we would ask one thing back in return, which is just that when you get your email with an evaluation form, not to do what we all do, which is to delete them and ignore them, but actually to fill them in, because it helps us a lot to organise future events. So bang on time, I'd just like to point out, we have reached the end. So I'll just say thanks to everyone again, and remind you that the recording will be available next week, and you'll be notified of that, and if you get that, to share it widely. So thank you very much and good afternoon.
And thanks to the panelists and to you, David.
Thank you.
Thank you. Bye-bye.
Bye.